Here are objectives for your GU lecture. Here is just a visual and review for you of what all makes up our urinary tract and what each thing does: kidneys, ureters, bladder, urethra. Differences in children. Obviously, the urinary tract is the same as an adult's, but just smaller. A child's kidney is about the size of a computer mouse, so 5 inches by 3 inches. And their bladder size, how we equate how much a child's bladder should be able to hold, is actually the child's age plus 2, and that would be the expected amount in ounces that a child's bladder could hold. And then everybody now has been through clinical, so you also know how we calculate urinary output for kids, that 1 to 2 cc's per kilo per hour. So as we talk about GU issues that we see in our kids, one of the most common ones with elimination is enuresis, or what's otherwise known as the ability to control urination or bedwetting. It does typically happen at night, but it can also happen during the day. So enuresis is 50% more common in boys. Again, it can occur during the day or at night. If it does occur at night, it's called nocturnal enuresis, but typically we'll consider it enuresis if the child is older than 5 years of age, because by that point all children should be able to control their bladder and should be potty trained. This usually does go away between the ages of 6 to 8 years of age, and it can be hereditary. So when you're doing that initial assessment and getting your history, it'd be important to find out if there is a family history of bedwetting or not being able to control their bladder or urine after the age of 5. So 2 main causes for enuresis are, they could be physiological causes or psychological causes. So first, starting with the physiological causes, one of the most common ones is that there's a neuromaturational lag, meaning that neurologically they're unable to control the lower urinary tract, or it's not as developed as it should be. So they basically have breakthrough peeing. There could be an infection going on, and that's why they may, with the amount of frequency in urination, are unable to control it and then accidentally wet their pants. Or it's simply because the bladder size is too small for their body. Because at night, think of kids, especially if they drink a lot before bed, they potentially should have to hold 300 to 350 cc's of urine at night, and if the body or the bladder just hasn't caught up to the size of the rest of the child's body, then the bladder just simply may not be big enough to hold all the urine it needs to at night. So psychological reasons we see related to enuresis could be simply the child is just, their brain is not waking them up at night. They sleep very soundly and they aren't waking up when they have the sensation that they have to pee, or they may be having dreams that they're peeing. And think it's truly just a dream, but they are actually peeing. Emotional factors do play into this. If the child is extremely stressed or anxious about something, like at school, they're being bullied, things like that, that could lead to them having some enuresis. Or again, like I said, family history or a history of family disruption or other emotional stressors. When we think about psychological issues, though, I know a lot of times students want to jump to the conclusion, oh, well, maybe the child's also being sexually abused. There have been no proven cases or consistent links between sexual abuse in children and enuresis. So the nursing care we want to implement with these children and their families when they are diagnosed with having enuresis is first that evaluation piece, evaluating and assessing the child's self-esteem. If you are aware that the child is having some stressors, what type of coping strategies does the child have, or what available support systems are there for them? How is the family coping with this? And how does the family, as a whole unit, when, like in the beginning of the semester, we talked about family stress theory. And so how is the entire family coping with this? Or if there's a stressful situation or event going on, how is the family as a whole dealing with this, the stressor that's occurring? Does the child have any friends or peer groups, support groups? Is the family supporting them? And then we need to teach parents some tips to help prevent the enuresis from occurring. So educating the child and the parents about restricting fluids at night, especially avoiding fruit drinks and caffeinated, carbonated beverages after 4 o'clock in the afternoon. Avoiding using pull-ups while they seem to be a good idea, because then the parents don't have to worry about the child making a mess in bed or changing sheets. It actually does the opposite thing, because the child knows that they basically won't get wet, or they won't wet their sheets or anything, that they don't feel as conscious about not peeing in their pants. So the kids should still be wearing underwear, not resorting to using pull-ups all the time until the enuresis passes. Parents should avoid punishing, scolding their child, reprimanding them for peeing in their bed, because again, as we've just talked about, a lot of times it's not truly the child's fault that they're doing this. They aren't intentionally peeing in bed or peeing their pants. Avoid siblings from teasing them, or friends. You might have to avoid sleepovers for a little bit so that they don't become embarrassed if this should happen if they're at a sleepover or party. Keep a calendar of wet and dry days so they know, if they're accomplishing a number of dry days, that they do have that sense of accomplishment and something to work for. So what other treatment is there for enuresis besides the nursing care we're providing and teaching we're doing? We can do bladder training, or teach parents how to do bladder training, and that's basically setting up a schedule whether the child really feels like they need to go to the bathroom or not. Having them just schedule going to the bathroom. And that means even at nighttime, waking them up in the middle of the night to retrain their bladder and to go to the bathroom, and how to train it to hold X amount of fluid, and how to release it when the child is ready. Conditional reflexive response devices means like the pads that you can put on a bed. So if a child would happen, like at night, to start peeing in the bed, it gets wet and alarm goes off. So it would wake up the child. Another thing that we can use also is antidiuretic hormones, which can be taken orally or nasally, and this will reduce the urine volume in general that the child has. Again, hopefully so that they can hold what there is in their bladder. So another common genitourinary issue we see with kids is UTIs. We aren't going to spend a ton of time on it because it is symptoms are pretty much exactly the same as they are with adults. For teaching with parents, if they're asking why, did my child get a UTI, or why are they are more common in girls, and that's simply, you can tell the parents, because young girls have a shorter urethra, so that's why they are more susceptible to getting UTIs. Diagnosing UTIs in kids, same as with adults. We just get a urine culture to check if there's bacteria in the urine. The other thing, in kids, we may do further imaging, especially if a child is frequently getting UTIs. We may do what's called a VCUG, or voiding cystourethrogram, and that's just so we can assess or check if the child is having some refluxing, and that's where urine is going back up into the ureters and therefore causing the UTIs. So just remember that we may do that, and we'll talk about refluxing in the upcoming slides. So treatment goals for UTIs in our kids, same as with adults. We just want to prevent the spread of the infection. We want to treat it as efficiently and quickly as possible. If a child does have, again, repeated UTIs, then we want to figure out what is causing this infection. You know, is it just bad luck? They have poor wiping techniques if it's a girl, or is it an obstruction? And again, as I spoke about in the previous slide, that's when we would start doing some of these imaging studies to see, again, structurally, is there something that is causing the UTIs, or is there an obstruction going on? Because our ultimate goal is to preserve complete renal function. We don't want a child end up having, you know, acute renal failure or chronic renal failure, some kidney damage because of the number of UTIs that they have occurring. So most common treatment for UTI, same as with adults. If it's a one and done, we've ruled out that obstruction. We're going to treat them with antibiotics. So as a nurse, your role is to teach parents. The child should complete their full course of antibiotics. Make sure they're taking it every day, and that full course often is 10 to 14 days of antibiotics. Making sure that the child is drinking enough fluid. For older kids, that's going to be 1,000 mLs of fluid a day. For our younger kids, everybody now has been through clinical. You know how to figure out maintenance fluids to make sure that their urinary tract truly is getting flushed out. I would figure 1.5 times maintenance of fluid for those kids because it'll help wash out the endotoxins and tissue debris. Again, remember, fluids would include clear fluids, would be juice, soup, milk, ice cream, gelatin, frozen liquid desserts. So they can, aside from just drinking it, get fluids in multiple facets. Cranberry juice is always good. But teaching them to avoid caffeine and chocolates is huge. Teaching them that the child should be voiding every 2 to 3 hours and emptying their bladder completely. If the child's in school, writing them a note so the teacher allows them to go to the bathroom that much. Typically when kids start school, that is a very common time that we see, especially little girls, start to develop UTIs, and it's because they're afraid to ask their teacher if they can go to the bathroom, so they're holding their urine. Other things to teach them, wearing cotton underwear helps to prevent UTIs, making sure little girls are wiping correctly, wiping front to back, minimizing the amount of bubble baths that they are taking. In our household, taking bubble baths was a treat for the girls because it did help minimize UTIs. And when they are bathing, period, not letting them sit in that dirty, scummy water for long periods of time will help minimize the amount of UTIs that they're getting. And because UTIs can be painful, advocating and telling the parents it's okay to give them Tylenol or treat them with ibuprofen if the child's over 6 months. So if a child does have repeated UTIs, we're going to do a further workup to see, again, is there an obstruction causing this, or is there refluxing going on, which is also known as vesicoureteral refluxing. And that basically is during voiding, urine is swept up the ureters and then flows back into the empty bladder where it sits and grows bacteria till the next void. The refluxing doesn't necessarily cause the infections, but it is clear that refluxing is more likely to be associated with recurring kidney infections, UTIs. So that is why we do check to see if there is refluxing going on if a child has repeated UTIs. And again, aside from just frequent UTIs, if they have frequent kidney infections, more kidney infections can result in more kidney damage. And again, our ultimate goal is to preserve full kidney function and to avoid any damage to the kidneys. So the tests that we use to show if there's refluxing going on versus an obstruction is again, the VCUG, which is avoiding cystourethrogram. And there is a grading scale that we use to grade how severe the reflux is, which we'll talk about more in the next slide. So treatment for refluxing, again, we're going to do a VCUG and grade the refluxing. Again, I said the grading was 1 to 5. 1 is minimal refluxing going on. 5 is the worst. It is very important to grade the refluxing in order to appropriately manage the treatment and to give the parents an accurate prognosis. The more severe the reflux, the lower the rate of spontaneous resolution and the higher incidence that there can be scarring in the ureters. And potentially, if it goes undetected, the child may need ureteral implants. But for mild to moderate refluxing, we can do what's called a sting procedure, and that's where we inject a bulking agent into the mucous membrane of the ureter, and that basically prevents the reflux from occurring. With severe reflux, they are put on chronic antibiotics or continual antibiotics. Oftentimes, we may have to do a surgical intervention and actually reimplant the ureter. So then we'll move on to our glomerular diseases, which are the two main ones: nephrotic syndrome, which is a massive amount of protein in the urine, and glomerulonephritis, which can be acute or chronic. So first we'll go over nephrotic syndrome, which is the most common presentation of glomerular injury in our kids. When these kids come in, they have edema. That is the main thing that is noted in these kids. And the reason they have the edema is because of the amount of protein that's in their urine and the decreased albumin. So if we run labs, we're going to see that. The kidneys have been damaged somehow, causing them to leak large amounts of protein from the blood into the urine. It could be possibly because of chronic infections. And our goal then ultimately is to decrease the excretion of urinary protein and maintain that protein-free urine. So more specifically, how are these kids going to look when they're presenting and they have nephrotic syndrome? What I always tell students, think of your CHF patients. Again, number one characteristic is that, an evident thing is that edema. They're going to have that weight gain, but yet they're going to be anorexic. Again, because their weight gain is because they are retaining that fluid, but they can be anorexic because of their decrease in appetite. They're truly not getting the nutrients that they need or holding on to it. The edema is going to be the exact same places that we see it in our CHF patients. Puffy eyes, their legs, their cankles that they may have because they're so swollen in their lower extremities, and just sheerly tired. These are kids, again, that parents are saying it's odd. They don't want to play with their friends, or they are playing with their friends and they come in really quickly because they're very tired. So they're very lethargic. Again, that decrease in play, key sign something's going on with these kids. And their urine is very dark and frothy. So if they're young enough that the parents are able to see the child's pee, they're going to notice that. Or most likely, if the child is older, they still would be saying, to their parents or their mom that their urine looks really funny. It may look like root beer soda because it is dark and frothy. So treatment plan for kids with nephrotic syndrome, minimizing that fluid retention, decreasing that edema, getting those fluids off so we aren't increasing the work of the heart. So decreasing sodium, we may restrict fluids, putting them on steroid treatment. But again, like we talked about with Cushing syndrome, making sure that they aren't on the steroids too long, and teaching parents about long-term side effects of steroid use, and then also doing that teaching that when the child is taken off of the steroids, that they shouldn't be stopped abruptly, that we need to wean these kids off of the steroids. And then also working with the child, especially dependent on age, about their body image because they are so puffy and retaining that fluid. And, girls always think they look fat anyway. Well, now they really look heavy. So, working with the child and parents regarding body image. Again, they're lethargic, so they may be laying around more, and promoting good skin integrity with the parents, making sure that even if the child doesn't feel like moving, they're moving the child, having them reposition themselves using moisturizers and lotions to protect their skin. So as I mentioned, the other type of glomerular disease is glomerulonephritis. Can occur in the acute or chronic form. With glomerulonephritis, just think post-infectious renal disease. With acute, we typically will see it occur 1 to 3 weeks, following a streptococcal infection. In winter, it's usually pharyngitis. We'll see this after, or in summer, usually after a skin infection. With chronic glomerulonephritis, it can occur after the acute phase or slowly over time. And there is a poor prognosis, unfortunately, with chronic glomerulonephritis, or there can be hereditary nephritis, or what's called Alport syndrome. And that's the most common hereditary glomerulonephritis, and it's caused by a gene mutation. And typically with glomerulonephritis, no matter in the acute or chronic phase, they usually experience some vision and hearing loss, which is associated with this. So with acute glomerulonephritis, like so many of our diseases that kids present with, getting that history is so important, because when you are, you may be able to detect what exactly is going on simply by getting that good history from parents, because they may say, my child, again, winter, my child just had strep throat 1 to 3 weeks ago or a few weeks ago. That may make you think, oh, maybe they do have glomerulonephritis going on. Some are after a skin infection, but they've had some type of streptococcal infection that had been going on a few weeks before this. Again, symptoms are that edema, but yet they're anorexic because they have that decrease in appetite, decrease in plasma filtration. Urine typically is cloudy, smoky, browny colored. Again, a child stating or telling their parents, or the parent themselves being aware that the urine doesn't look right. It's not that yellow color. It's not clear. It's very cloudy and very dark looking. Again, child's not playing because they're very lethargic. So those are a lot of the same symptoms that we see in our kids that have nephrotic syndrome. But again, the difference in their urine, though, is that with nephrotic syndrome, it's frothy looking and dark, and with acute glomerulonephritis, they have the cloudy, smoky, brown-looking urine. Usually it runs its course in a month, and if we do a urine analysis, it's going to show hematuria, so that blood in the urine, and that excessive protein in the urine, or proteinuria. So treatment for acute glomerulonephritis, main focus is getting rid of the edema to minimize the workload of the heart. So dietary restrictions, decreasing the sodium, decreasing fluids, decreasing potassium, which will help with all of that. Restrict protein for these kids. Limit their activity, but most of the time these kids don't mind limiting activity because they are so tired. Using diuretics, again, to get that fluid off, decreasing the workload of the heart, putting them on antibiotics for 10 to 14 days. A lot of times we can tell the child's getting better because their urine output increases, and we can just physically see that decrease or reduction in edema in the child. And they're probably, they're going to want to start playing again. We know that they're feeling better. So, as always, one of our main roles as a nurse is doing teaching with the parents, teaching them to watch for signs of blood in the urine, decrease or increase in edema, more puffiness if the child is complaining of headaches. Again, the child's going to be lethargic, so they'll probably be laying around more. So also doing that teaching with parents about good maintaining skin integrity and repositioning the child if they aren't repositioning themselves. And then also, while there's the kick of people shouldn't be on antibiotics, we're pushing antibiotics too much, but yet we have to use our common sense. And when kids do have infections that are bacterial, we need to put them on antibiotics. Or if a child has strep throat, we need to treat the strep throat. Because again, we've learned multiple times throughout the semester how different how having strep throat and letting it go and treat it can cause so many other co-problems or comorbidities in kids. So then lastly, before we talk about structural anomalies that we see related to GU that we see in our kids, we're going to cover renal failure only briefly because, again, same in kids as with adults, and it can occur in the acute or chronic form. So HUS, or hemolytic uremic syndrome, is the most common cause of acute renal failure in children younger than 3 years of age. It's characterized by hemolytic anemia with fragmented red blood cells and thrombocytopenia. So basically there's abnormal premature destruction of red blood cells, and the damaged red blood cells start to clog the filtering system of the kidneys, which then results in the acute kidney failure. 90% of the time it's a result of another disease. Most often it's E. coli. Typically they'll develop HUS 2 to 14 days after they've had E. coli, or if they've had bloody, watery diarrhea for some reason. Other symptoms that we see in these kids is, besides the diarrhea, fever, vomiting, abdominal pain, lots of pain, a lot of lethargy, again, because a lot of times they're becoming very dehydrated, pale looking, decreased urine output, confusion, they may bruise easily. Prognosis is really good if we catch this early on. Sometimes temporarily they'll need some peritoneal dialysis and may need some blood transfusions because of the amount of blood that they're losing. But again, teaching with parents is that if we can catch this early, it was caught early, prognosis is really good for these kids. Now, if they have the heterogeneous group of this disorder or streptococcus pneumonia, then the prognosis is more poor. But again, key thing is just detecting it early and getting the child treatment and then supporting the child and the family. So moving on to acute renal failure, basically it's just that sudden inability of the kidneys to regulate the volume and composition of urine. So acute renal failure is not very common in children, but our infants tend to be our most vulnerable because of their immature kidneys and their large body surface area compared with the body mass. One of the main things that we do see or that parents will report is that decrease in the urine. So again, everybody was taught minimum urine output should be 1 to 2 cc's or mLs per kilo per hour. In our kids that have acute renal failure, failure, we're going to see as little urine output as possibly a half a cc per kilo per hour. So a lot of times too, these kids become very hypertensive, and that's secondary to the systemic illness. And I've mentioned this in I think almost every clinical group, but again, if our kids start to have hypertension, as pediatric providers, our first assumption is not that there's a cardiac issue going on with the child. We do correlate hypertension right away. We want to evaluate their renal function. And then if we rule out there aren't any renal issues, yes, then we move on assuming that their hypertension is related to a cardiac issue. So something, again, very different than with our adults. Kids can become very dehydrated, which can cause acute renal failure, like if they had a poison injection, post-surgical things, they've had excessive fluid losses from trauma and bleeding, and losses from the GI-GU system, which can cause acute renal failure. And same with adults, usually our acute renal failure is reversible. So here are the common complications we see in kids that have acute renal failure, same as with adults. But with our kids, because we're always thinking respiratory, always remember to assess for these and shortness of breath, which may indicate that volume overload from the fluid retention. So chronic renal disease is a progressive loss of kidney function. Our most prevalent causes in our kids are uropathies and or glomerular diseases. Could also be caused from congenital malformations, chronic refluxing that's going on, causing chronic UTIs, causing kidney damage or kidney scarring, therefore causing chronic renal failure. Our major complication we see then in our kids is that edema and that water and fluid and sodium retention. What we do to test for this is what's called a creatinine clearance test. So we do a 24-hour urine collection, and what we do is draw a creatinine level during or at the end of the urine collection to see where their creatinine level is at. So again, one of our main roles as nurses is to do teaching with the child and family about chronic renal failure. Main thing, unfortunately, is that it is irreversible, so the child will need to be on dialysis until they can get a kidney transplant. Promote maximum renal function, treat symptoms, controlling that hypertension, which also can lead to some growth failure, so promoting as much growth as possible. Anemia, recurrent infections, we want to encourage them to have a diet low in phosphorus, and just preparing them and giving them support regarding the thought that this is terminal and that the child will ultimately need a kidney transplant. So lastly, we're just going to quickly cover some congenital urinary defects that we see in our kids. One of the most common ones is what's called a hypospadias, which is where the opening of the urethra is on the underside of the penis or the ventral side instead of at the tip like it should be. Typically, this is detected immediately or shortly after birth or in infancy. If it goes undetected, let's say it's a very small hypospadias, typically it'll be detected when the child is peeing standing up and they continually are spraying their urine everywhere, which is very annoying to mothers. So usually the moms will bring them in for their own sanity, asking the doctor why their child cannot pee directly in the toilet like they should be. So then another congenital urinary defect is just the opposite. It's what's called epispadias, and it's more rare than hypospadias. Again, present at birth, but that's when the urethral opening has a dorsal placement, so it's on top of the penis instead of the normal urethral opening like it should be. Again, usually seen right after birth, because it's very evident when you're changing the child, but we want to correct this also because it is a very easy access to bacteria, so these kids will have chronic urinary infections if this is not corrected. So again, most of my experiences with hypospadias repairs, because honestly, epispadias is so rare, I've never seen it. For hypospadias repairs, the treatment is a surgical repair. If it's mild, it can be one procedure. Most of the time, though, it's a two-step procedure, typically done between 6 to 12 months of age, and the surgeries are 6 months apart. The reason we do the surgery is so that the child can pee in a standing position, also for looks, to preserve a sexually adequate organ. With these children, one key piece, especially as an OB nurse, if the child is diagnosed with hypospadias, you'd want to do teaching with the parents that they should not circumcise the child immediately, because we would use or will use the extra skin for surgery. And what is done, a new meatus is created, and you close the hypospadias, and then a stent is placed, or basically a urinary catheter, to use as a urinary diversion, so that the new meatus can heal. So typically what we do is put one diaper on against the skin, which we can also educate parents to put some lubricating jelly over the tip of the penis so it doesn't stick to the diaper. And then we take that catheter and divert it out of the first diaper to keep any urine away from the new meatus and into a second diaper. So that's why we do double diapering with these kids. If they do have a stent in, you should teach parents to avoid tub baths till the catheter is removed, which is usually 5 to 10 days after the procedure. The child, no matter if there is a stent placed or not, will have a dressing on. If they do not have a stent, you can teach the parents that the dressing typically will come off 1 to 2 days after the procedure. And if they do not have a stent in, then the child can go in the bathtub. And a lot of times what will even happen, if the dressing hasn't fallen off, it will in the bathtub. But again, other things you want to teach parents, if the child is a little older, that you want the child to avoid riding on any tricycles, toys that they would sit on that might put pressure on their penis and on the new meatus that was created. So bladder exstrophy, as you saw in the previous slide, is where it's a congenital abnormality, and basically the baby is born with the bladder on the outside of the body. It is very rare, although in my nursing career I have seen this twice. It does occur more in males than in females, and can cause a lot of long-term problems, urinary problems, especially with infections and urinary incontinence. And there is a good picture of it, or pictures also, in your textbook on page 856. So the main nursing care that we want to provide for kids that have bladder exstrophy is that preservation of bladder and its function. So as an OB nurse, you would want to keep the bladder and any organs that are coming out of that same site moist, kind of like when we talked about umphaloseals with our GI. You want to cover the bladder with a non-adhering plastic wrap. We would not use, and you want to remember that, do not use Vaseline gauze because that eventually can dry out. Using a plastic wrap, however, that won't adhere to the bladder. Again, plastic wraps in moisture, maintains its own moisture. These kids will be swept off to surgery fairly quickly. It may be able to be repaired in one procedure, but often it's multi-step surgical procedures where we put the bladder back in, close the abdominal wall. We might have to do some reconstruction of the bladder. But in the end, the ultimate goal, again, is maintaining bladder function and preventing any necrosis from occurring, so we can, best outcome, have optimal bladder and urinary function. So lastly, two other urinary problems you may see in our kids, in our boys, is a hydrocele, which is a fluid-filled sac, along with the spermatic cord within the scrotum. Usually we will do a repair on the hydrocele or simply remove the hydrocele, and it's a in and out day procedure for these kids. Also, another common one in boys is cryptorchidism, and that's when one or both testicles fail to move into the scrotum before birth, or that they don't move through the inguinal canal into the scrotum. Typically, how we detect this in kids is that the testes or testy is non-palpable by the parents or the physician on exam. 80% of the time it will spontaneously descend by 1 year of age. So typically we don't treat this until the child's over 1 year of age. But again, as far as us as nurses go, teaching is so important with the families, and teaching them. A lot of times parents are concerned if the testes haven't descended into the scrotum, right away they freak out and they think, oh my God, will my son be infertile and not be able to have kids? If it's one testy only that hasn't dropped into the scrotum, typically there's no change in fertility at all. The kids are totally fine, very fertile, can still have kids. If it is bilateral, they might have a slight decreased fertility rate, but again, doing teaching with parents that most likely their child still will be fertile and be able to have kids. So our main nursing implications for hydroceles and cryptorchidism is talking to the parents. Both need to be surgically repaired. They are day surgery procedures. Both procedures will not be done until the child is over 1 year of age. For cryptorchidism, it's called an orchiopexy. Again, we wait to see if the testicle does or testes do drop in that first year of life. If not, we will do surgery. For hydrocele, same thing. If it persists past 1 year of age, then we do surgery. For both procedures, teaching with the parents is the same. Very common that the child will have some discoloration and swelling of the scrotum after, so parents should just monitor that if it's getting any worse. Straddle toys should be avoided for 2 to 4 weeks, and any strenuous activities should be avoided for 1 month in older boys if it's done later on in life. Even like bearing down should be minimal. And then again, discussing with parents fertility rates. And just let me know if you have any questions.